CNS disorder, psychiatric disorder in the DSM, you have to exclude other conditions or medications or psychiatric conditions that they have in order to make the diagnosis. So that's a new little piece that they added this year around. As far as signs and symptoms, they did add a sentence saying, and recognizing that the signs and symptoms for concussion are non-specific and can be caused by other conditions. Otherwise, the recognized signs and symptoms of concussion haven't changed, and we've already seen these in Ryan's talk this morning, so these are the exact same as the Zurich guidelines. They next go on to talk about sideline evaluation if you're doing any event coverage. So if you suspect a concussion and it has clear signs such as loss of consciousness or they're posturing or they have a seizure, they're immediately removed from play. And not to be returned. Whereas if they have suspected concussion with no signs, they need to go on to a sideline screening evaluation, and this can use tools like the SCAT or the King-Devick. And based on this assessment, you can either say that they have no concussion and they can return to play barring any other injury, or they need to go on to a further diagnostic evaluation, which is removed from the sideline in a medical room or a quiet room. Similarly, if you've removed them from play based on the signs of concussion, they need to go into the medical room and have a full assessment as well. And then based on that, you can decide concussion or no concussion. Not much change from last year, but it's a little bit more algorithmic approach. Other things that they recognize on the sideline assessment, so the SCAT5 is new this year. They also recognize that sideline video review plays an important role if you have access to it. They also recognize that ocular motor screening and reaction time tests could be useful. And then this is the one time that they mention that you need to exclude a more serious injury. I actually feel that this should be in the diagnosis and definition section because concussion in itself is a diagnosis of exclusion. And I think they need to recognize that a little bit more in the definition and diagnosis. But they do recognize it here. As far as the cue management, this hasn't changed. So if a concussion is suspected, shouldn't return to play, and then they should have a reevaluation within 24 to 48 hours, screen for more significant injuries, and use neuroimaging if indicated. As far as concussion-specific investigations, when you've ruled out other injuries, there are no investigations recommended specifically for concussion. There's a lot of research going into biomarkers, but none of these are ready for prime-time clinical use yet. As far as rest, so rest has always been a main piece of concussion management. In this iteration of the guidelines, they actually use the word complete rest, and that there's insufficient evidence for complete rest at this time, which I think is a good step forward. This is the same as Zurich, so after a brief period of rest, 24 to 48 hours, you can start a graded progression back to sort of life activities. And this 24 to 48 hours piece has actually been there since 2012 in the Zurich guidelines too, so that's not new either. So looking at the progression, so this is the return to activity. Ryan already went over this morning, and this hasn't changed at all since 2012, so that's the same, and it's the steps that Ryan discussed this morning. This is new. They did have discussion piece around return to learn in the 2012 iteration. But in the new guidelines, they do actually have a 4-stage return to learn. I don't know why they went with 4 stages when there's 6 stages in the return to physical activity. At U of T, we have 6 for both, and they vary a little bit. And I'm not going to talk about this too much because we have a world expert in return to learn, Dr. James Carson. He's going to speak about this in the afternoon. But this is their sort of recommendations with respect to return to learn. I know it's really small, and you can look at it on the guidelines after. As far as other rehabilitation techniques that they recognize in these guidelines, there's a few of them. So they say there is a role to play for psychological, cervical, vestibular, and active rehabilitation techniques. They also recognize that in some situations, pharmacological intervention is required as well. All right, so this is the first section that probably the major changes have happened to compared to this one to the Zurich. And that comes to neuropsychological assessments, and these are tools like impact tests or A&M tests or brief neuropsychological batteries. So the guidelines themselves recognize that they previously said NP assessments were the cornerstone of treatment, and they still recognize that it does have value and contributes information, However, the next section that we're going to talk about now is where things drastically change. So they recognize that NP assessment should not be the sole basis of management decisions. They say that post-injury NP testing is not required for all athletes. And brief computerized, all the NP testing should be performed by trained neuropsychologists when available. And then they say brief computerized cognitive evaluation. So these would be like your impact tests, your ANAM tests, and those are not substitutes for a full neuropsychological evaluation. And they do recognize that baseline or preseason NP testing is not required for all athletes, which I think baseline testing we're sort of shifting away from almost. So that's the first major difference between this and the last iteration. The next one is with respect to persistent symptoms. So as far as the concussion group in sport is concerned, post-concussion syndrome no longer exists. They now label it persistent symptoms. And how do they define this? They define it as a failure of normal clinical recovery. So they recognize this as symptoms that persist beyond an expected recovery time. And I think there's a lot of debate, as we've talked about this morning already, about what this recovery time is. The consensus group suggests that it's about 10 to 14 days in adults and approximately 4 weeks in children. And there's evidence that says shorter and longer, so I think this is very controversial at this time. With respect to persistent symptoms, they recognize it does not reflect a single pathophysiological process. It is described as a constellation of non-specific post-traumatic symptoms and may be linked to coexisting or confounding factors. And this is an important piece. They say it does not necessarily reflect an ongoing physiological injury to the brain, which I think is important. And when I've explained this to patients, I've seen both reactions. Some people are really relieved to hear that 2 years after their concussive injury, they're not still having a physiological injury to the brain, and some people are very defensive about the underlying pathology of their injury. So, but I think this is an important step forward as far as dealing with people with chronic symptoms. All right, moving on. So they do have a section about establishing recovery, and this is all the benefit, or this is all they give you. They say it's a difficult task. They don't give you any further guidance with respect to establishing recovery. They do have a special population section, which I think is good. So with respect to elite athletes, there is no difference in how you should be managing, which I think is an important point. As far as the child and adolescent athletes, they say that they should not return to sport fully until they return to school fully, which I think is an important piece. And they do recognize that early introduction of symptom-limited physical activity is appropriate. The next section, although I've crossed out chronic traumatic encephalopathy, they do talk about it in the guidelines. However, it does not have its own heading or section now. And just speaking to colleagues of mine who work in concussion, they feel that the guidelines have been a little bit soft or weak with respect to defining the association between repetitive head injury and long-term injuries, and I think it is probably a little bit weak. But this is what they have to say. So you say clinicians need to be mindful for the potential of long-term problems in the management of all athletes. That's the first thing they say. They say the literature on long-term consequences of exposure to recurrent head trauma is inconsistent, which is true. They say there's much more to learn about the potential cause and effect relationships of repetitive head impacts, exposure, and concussions. That's pretty much as conclusive as they get. They do have a paragraph on CTE, and they say the potential for developing CTE must be a consideration. And how they discuss ETA, they do recognize that it is a distinct tauopathy with unknown incidence in athletic populations. The cause and effect relationship between CTE and repetitive injuries and concussion has not been demonstrated. And the notion that repeated concussion or subconcussive impacts cause CTE remains unknown. So not very conclusive. As far as prevention of concussion, they go through a few variables. So the first one they talk about helmets. This hasn't really changed since the last iteration, so evidence is limited for an overall effect for reducing concussion incidence. But they do report that there's sufficient evidence for helmets and their use in skiing and snowboarding for preventing overall head injuries. As far as mouth guards, so again, evidence is limited, but this is new in this iteration. They do say that there's one meta-analysis that suggests a non-significant trend towards protective effect with respect to concussions in collision sport. So I'm actually not familiar with this meta-analysis. I'm going to go look it up myself, but so that's new. As far as intrinsic risk factors, so this would be like things like cervical neck strength or ocular motor, visual tracking, preventative techniques. They said there's no evidence for any of these. The strongest evidence comes in the form of extrinsic risk factors like rule and policy changes. So the SCAT5, so I'll just touch on two quick points about it, then we'll just go through it briefly just to highlight the differences between the SCAT5 and SCAT3. So it is useful, they do say it's useful to use acutely and immediately for identifying concussion. However, they do recognize that its utility decreases after about 3 to 5 days. The symptom checklist part of the SCAT is, however, important to track recovery. And baseline testing, again, may or may not be useful. So let's just quickly go through the SCAT5. So this is all available now for you guys online to access. And in overall, the SCAT5 is very, yeah, sorry.
Just, did they have any discussion about repetitive concussions?
So that was it, pretty much. That's the long-term sequelae, yeah.
Treat them all the same.
Yeah. Alright, so SCAT5, overall very, very similar. So I'll just highlight a few differences for those of you who are familiar with the SCAT3. So this is the immediate on-field assessment section. The only difference between this and the previous one is a new cervical spine assessment. And I know it's very small and you guys can read it on your own time. When we go into the office assessment, the only differences are, so if you scroll down, they give you an option to do 10 words as opposed to 5 for the immediate recall and delayed recall. They also increased the length of the digits backwards, so it goes up to 6 now. The only other thing that they've added is this little neurological screen, which screens sort of verbal fluency, another neck exam, an ocular motor visual, another visual screen, coordination, and attainment gait. And that's the only thing that's been added. Other than that, it's the same. Okay. Any questions?
For outpatients who come in like a week after they've had an initial injury, I often use that Rivermead checklist that's in our custom forms.
Yep.
Is that comparable, or should I be going right to the SCAT?
No, it's comparable. I think it's been validated more in a broader spectrum of brain injury, but you can use it for concussion as well. I think this is the SCAT symptom checklist is a little bit more ubiquitously used, so it might be more valuable if you're sort of communicating with other people as far as the recovery.
This was something that was discussed at the conference. Essentially, like, it's not designed as a office tool, but most people still use it to some extent, whether it's just the symptom checklist or some of the exam periods. So, you know, the question is, why are you doing the symptom checklist? You're really wanting to know the severity, which we know corresponds to how long they might be out for, in terms of if they have a really high score on a Rivermead or a SCAT3, they're going to have symptoms for longer.
Even if you don't do the full SCAT, if you can just do the symptoms score for them, because that way if it doesn't resolve and you end up sending them on to sports, it's really helpful for us to compare.
So based on this, I guess we shouldn't be restricting somebody from returning to play just based on the neuropsych testing. Like if that was the only domain that they still had to return back to their quote-unquote baseline,
yeah,
we wouldn't necessarily need to restrict them.
What neuropsych testing are you referring to?
So,
like the SCAT?
No, not the neuropsychological assessment.
Yeah.
They were saying that, you know, it's not required necessarily. Yeah. So as like I know at UFT for some of the varsity athletes, the final return to play decision, you know, if it's still delayed, we sometimes hold them back.
Yeah.
So would that change now?
I think these guidelines just highlight the fact that you need to look at other factors as to why there might be changes in the neuropsych testing, like other conditions. But I think truly, if they flunked their neuropsych and you do have a good baseline, you need to seriously consider whether they should be going back at that time or not, if you can't exclude other contributing factors.
Here's not five. You use the King Devitt test?
Yeah, I do.
You have any familiarity with that? We
Yeah.
use that, but
Yeah, I use it very.
yeah, has it been validated a little bit
Yeah.
better?
It has been validated.
Right
but
after the injury, we do it a lot of times.
Yeah. So the way I use it, I'll do a SCAT, and I had a case of this on the weekend. And if it's completely normal, I'm still suspecting concussion, then I'll go on to the King Devitt. If they flunk their SCAT or their symptom scores high, then I don't find it adds any predictive value. So there's no point in helping rule out concussion at that point if I've already made my decision. Any other questions? Nope. Okay.